So good afternoon, everyone. Absolutely lovely to have so many people joining us today. Really appreciate your time. We're very aware that the pandemic is far from over and people are still very, very stretched. So you're taking the time to join this web chat. This webinar is really very much appreciated. My name is Jen Kenwood. I'm the Experience of Care Lead for Community and Primary and Integrated Care at NHS England, and I lead the Carers programme nationally for NHS England. This we've just been debating, we think, is the fourth of our Lunch and Learn webinars, the purpose of which is to really shine a light onto some of the fantastic practice that's happening within different localities around the country, and also an opportunity for you to meet some of our regional leads as well. In terms of housekeeping, could I just ask that you keep yourselves on mute while our speaker is presenting? If you have questions or comments during the presentation, if you could put those in the chat box. The speaker today is going to pause at a couple of different points, so we'll pick the questions up then. And we can also use the hand raise function on the icons at the top of your screen as well. So without further ado, I'm going to the other thing I should say is that we'll also be recording today. So if you don't want to be on camera, if your boss thinks you're somewhere else and you're watching from Tenerife, put your camera off. If you are watching from Tenerife, I'm very, very jealous. So we are recording it and there will be a transcription from that as well. We will also be sending slides from today out as well. So if you do want to see slides, they will be coming to you. So having done my housekeeping, I will now hand you over to Ros Spinks, who is our regional lead for London, who will be introducing our speakers today. Thanks.
Hello, thank you, Jen. Hello, everyone, and welcome. I'm delighted that London's getting a chance to our turn today. Really excited to welcome Sally Chandler, who's the Chief Executive of the Carers Trust Hillingdon. Hillingdon is part of North West London integrated care system, and they've been doing some really amazing work around integration for quite a few years now, actually, so they're very ahead of the game. One of the issues we have in London, and I'm sure this is reflected elsewhere, or one of the concerns people have, is how, particularly for smaller voluntary community sector organisations, how can they get at the table with health and social care providers? And I think Hillingdon, along with all the other boroughs in North West London, have done a really good job at organising themselves and really making sure that they're supporting the sector to have that seat at the table. So without further ado, I will hand over to Sally, who will tell you more about the journey. Thank you, Sally.
Thank you very much, Ros. If you could just turn the slide over for me, thank you. And again, so I've split the presentation into three parts, but what I really wanted to stress was that I haven't got all the answer to all of your challenges. Engaging with the emerging systems is massively challenging, particularly as they're developing very differently across the country. All I'm here to do is share our journey and hope that there's some tips or some information that might be useful to you. But there is a third sector leadership programme also run by NHS England via Carrie Mackenzie, who also run webinars. So, we can certainly put you in touch with those as well, which are particularly focused on third sector engagement with integrated care systems. So there's probably more appropriate information there. So I've broken the presentation into three parts. One is how we came to be where we are, so our local activity, and then we'll stop for a few questions. Then I've kind of looked at the North West London picture, and then because we're looking particularly at carers, where I perceive the benefits to carers have been from my engagement in this work. And just to say that's all been on top of the day job, it's not remunerated in any way. So the next slide really just talks about our kind of history. So back in 2014, if you look at the cogwheel part at the left of the slide, we came together with 4 of the other larger charities in Hillingdon. So AGK Dash is a local disability charity covering all sensory learning and physical disabilities, Harlington Hospice and Hillingdon Mind. And we created what was then a KIC, which is now a CIO, called H for All. And we were launched officially on the Charity Commission in 2015, and then early 2016 we secured what we believe to be the first voluntary sector seat on the Hillingdon Health and Care Partnership, which is the local integrated care partnership in Hillingdon, which actually, if you just flip over again for me, thank you, has 4 pillars. So can we flip the slide, Steve? So the 4 pillars of the local ICP are the 2 foundation trusts, so our Hillingdon Hospital and Central and North West London NHS Trust, our GP Confederation, and then H4All as third sector representatives. And what was really gratifying after banging on doors for 2 or 3 years was that we had equal voting rights in the care of the ICP with those much larger players. And that has obviously given us a huge opportunity to influence and impact locally. So just going back to why we created H4All on the next slide, please. We started talking together about how we could be stronger together. It was at a time where we were seeing a lot of aggregation of contracts into one, and when lots of pots of money are put together, they suddenly become very visible to large national charities who, often try to parachute in, and they're worthwhile for them. So we wanted to be stronger together, and by combining our modest incomes together, it gave us a lot more clout in terms of bidding for larger contracts. But there were a lot of other reasons for doing that. So we obviously wanted to drive more resources to the front line. So we've developed shared backroom services. We have a shared finance service. We merged 3 counselling services under one management and supervision structure, and that enables us to make savings wherever we can. And we also were able to, using economies of scale, save money on things like IT support, audit and other ways. So it was about making sure every penny really was spent where it was best meant to be. But it was also about simplifying access to the third sector for statutory services. So there's often a will in health and social care to engage with the third sector, but because it's so large and so diverse, a lack of understanding about what's out there and how they can better support residents by referring to the third sector. So what we set ourselves up was as a gateway to the third sector services. And we wanted to make sure we were embedding the third sector in the local ICP and making sure we had influence, so we could influence system change from within. And that wasn't just about the 5 sovereign charities, that was about us working with all health and care facing charities, groups, smaller groups, organisations in Hillingdon. What we try to do and what's been really, really beneficial is sharing our skills and knowledge and resources and preventing duplication. And we then set up a series of services that were really about tackling the wider determinants of health. So we've all, I'm sure, as charities, long banged the drum that health isn't just about a medical condition, and there has been a sustained focus really on medical conditions by health and care services. And what we were saying is actually, unless you really look at all the wider social issues, you're not going to get a healthy, happy population. So we developed, this is a long time prior to the social prescribing link worker programme that's been out for the last 3 years. We developed what we called a social prescribing plus model, and what differentiated it from what happens now is that all residents who were referred to our services was risk stratified, and we measured their engagement with their own health and management of long-term conditions through the patient activation measure tool, pre and post our interventions. So we were able right from the get-go to evidence impact of what we were doing. We also targeted residents that were lonely and isolated, tried to keep people socially connected, and really looked at how we could coach residents to better manage and understand their long-term health conditions. So that was the purpose of putting H4All together. So on the next slide, our services have developed right from top right corner, our wellbeing service, which was our flagship service, launched in 2015, which was targeted at over 65s living with one or more long-term condition, who were frail or who were lonely and isolated. And we've subsequently been able to make the case for investment in a range of other services. Our high intensity user service, which won an HSJ award last year, was specifically targeted at the top 50 users of A&E in Hillingdon, and they actually annually account for a £7 million health and social care spend. So 50 people were consuming effectively £7 million worth of resource. And we did very, very intensive work with those users and looking at 999 calls, A&E attendance and non-elective admissions 6 months before our intervention, 6 months after. In the first year, we were able to evidence over £250,000 worth of savings to the system for a modest 70,000 investment. We then had a service which looks at the next 4,000 users of services who account for 50% of the annual health and care spend and provide active case management as an integrated part of the care connection teams based out of the primary care networks. So we work very closely with residents with high need to try and not reduce necessarily, but make their usage of health and care services more appropriate. And then the bottom 2 or 3 are just new projects that we've got investment in. There's a lung health programme. My Health Hillingdon is a whole programme of workshops to help residents at their own pace understand and manage conditions such as diabetes, menopause. They're doing all sorts of different programmes there. And Compassionate Hillingdon is an end-of-life support programme. We also have a community resource centre that we took over. Was gifted to us, and we're developing that as a resource for the whole sector. And we have training rooms and hot desks that are available to all the smaller groups and organisations in Hillingdon. So that's really where we've got to in Hillingdon. And then we kind of got to a point where services were, commissioning was changing. It was polarised between the movement to the 8-borough ICS and with some spends determined at a neighbourhood level, which is where we moved on to look at North West London. But just before I sort of stop there for questions about the local arrangements, I'll just talk about a few achievements. So on the next slide, basically what we've achieved is effectively removing direct competition between the larger charities. You could just move the slide on, Steve. We don't ever compete with each other for funding. We always bid together as appropriate. I think what's been really instrumental in our ability to engage and influence is learning the language of health, and that gave us a credible voice. So what we had to do was understand the system's needs almost better than they did. So understand where the pressures were on the system and present problems, and that made us very credible. And it also gave us more influence. A lot of clients now return to our services rather than going back to the GP. All practices refer to them, and they are now recognised as a very credible alternative to clinical referral because there are some really positive and demonstrable outcomes from our engagement. What's been really helpful to me, and these are sort of unexpected benefits, is that kind of cross-organisational senior leadership. So for those of you that are chief execs of small local organisations, I'm sure you will not disagree with me that it's a very lonely role sometimes, and you're expected to be an expert in everything from estate management to organisational development to GDPR to IT, and which we're patently not. And what's actually happened with the 5 chief execs meeting weekly is that we all take on the roles that our skills sing to. So I do a lot of the writing for them. There's a guy who's brilliant with spreadsheets and supports me in all the budget work I have to do. And we get huge amounts of sort of mutual peer support from working together as 5 big charities. I've mentioned the money saving, and we have been able to push more money to the front line. And we're now able to invest and coordinate and work with the wider sector. So we have a local health and wellbeing alliance. We're slightly unusual in Hillingdon in that we haven't had a CVS or infrastructure body for a few years. So we've kind of naturally filled that gap. We're now delivering about it's actually £2.3 million next year's budget, NHS contracts. And that was money that was previously spent in acute clinical services that we've been able to make the case for investment in prevention and wider determinant work. So that's been a real sense of achievement for us. And we have a growing local reputation and national reputation as thought leaders. And that's why we kind of stepped up to try to protect that really hard-won influence as the system changed around us, and have engaged with a whole series of like-minded partners across North West London. So I'll pause there for, actually, there's just one slide, not that I'm desperately delighted about. The next slide, Steve, about the visit from our great Prime Minister. However, he did visit us he's visited us at the Carer Centre a couple of times as our MP, but when we won the HSJ award, he was very, very interested to hear about how the voluntary sector has a role. So we hope that even just those few words in his ear might help to influence what happens at Westminster. And that's our fantastic HIU team at the bottom there, with the sister from A&E who is part of the team. So I will stop and take any questions on the local stuff.
Brilliant. Thank you so much, Sally. That was a really good sort of start to 10 in terms of introduction, and it was brilliant to hear about how you've got round the potential for competition between small organisations coming together in that way, because certainly that's a tension we've seen in lots of other places, and also that real focus on the investment in prevention, which is absolutely what we see as a core thing within the work for unpaid carers. So there are a few comments, or a couple of comments and questions in the chat box. One is around, were any of the H4All members working across borough boundaries, and if so, how was that managed?
Yes, Age UK during our evolution merged with Age UK Harrow and Brent. So they are now Age UK Hillingdon, Harrow and Brent. It's supported our movement into North West London, our work in North West London hugely. Harlington Hospice provide services in Hounslow, and H4All indeed has been, up until recently, running the Link Worker programme in Hounslow. It's not been a tension because the sovereign charities still function as sovereign charities, and their delivery is not really linked to. So the H4All team is all seconded from the 5 sovereign charities. We've set up a shell company, if you like. What we didn't want to do was create another entity that was a potential competitor that needed feeding. So it doesn't have a staff team of its own at all. All the 47 staff are managed by the 5 sovereign charities in terms of HR, payroll, recruitment and all of that sort of stuff, so that we are not creating an extra spend, another tier of spend that's needed. So the H4All team is very separate from our teams, although we do have people that work across organisations or, will move across in roles, but it's certainly not impacted across borough boundaries.
Brilliant. And I think another really interesting question there from Kate is, how do you work with other charities that aren't part of that H4All group?
Okay. So we got some funding initially from City Bridge Trust. It's now largely funded through the council and the HHCP. We have the Health and Wellbeing Alliance, and we have a community development team that delivers effectively what an infrastructure body would. So that is providing capacity building support, training, help with governance, model policies and procedures, networking, information sharing, to take the rest of the sector with us. We've actually had 3 or 4 pots of money where we've been able to invest in grants for them, for the rest of the sector, and often we will include relevant other organisations in collective bids as appropriate. So if there's a speciality that we need that we don't have around the table. So we've really tried to level the playing field and make sure that everybody has equal opportunities, not just those charities that have the capacity to sit at H4All. So we have a series of H4All health partners who will carry our logo and benefit from joining the work we do.
Brilliant, thank you. And there's just a couple more that have pinged into the chat box before you go on to your next stage. One was, do actual carers have representation within this group?
No, obviously, so the carers work in Hillingdon, obviously it's Carers Trust Hillingdon, but we run a slightly separate partnership called the Hillingdon Carers Partnership, where we subcontract specialist support from the Alzheimer's Society, for the dementia support, Mind, and regulated care from Hillingdon Care. All of our services are carer driven. We have carer forums and the carer voice, but H4All is very much more focused on population health and well-being. I will pick up how it benefits carers, but that's my sort of third section. I will not leave the carers out of it, but at the moment they aren't represented necessarily on H4All, but apart from through me.
Okay, that sounds like your third section may actually pick up on that last question there from Suzanne rather, which is what does the user experience or journey look like from a carers and other, between carers and other service users? So it was just confusion, I guess, around that word user, but sounds like that will be picked up later on in your presentation.
Indeed.
Perfect. Okay, back to you again, Sally. Sorry, that wasn't the breather you thought you'd get, was it, between slides?
So could we move on? Slide. I think that you need to move on to Steve. That's it. So as I mentioned, we obviously had fought long and hard to get the influence we had at a borough level, and about 2017 we called a first meeting of our own network, so all the carers, all the age UKs, all the Minds, infrastructure bodies and a handful of other people to start to talk about this. That kind of stalled a bit, but 2018, when we started to see a lot of movement towards the ICSs, we started working together again and have been ever since. So just to talk about North West London, it's the largest ICS in the country. It's the pink area of that map, so it's 8 London boroughs. It serves a population of 2.4 million people. It's a £4 billion system. I also probably shouldn't say this, but I think it has the largest deficit in the country. So we are working against a very challenging backdrop financially. And in that area, there are 9 acute hospitals, 8 councils, 8 CCGs, 351 GP surgeries, and 45 primary care networks. So it's huge. Next slide, please. So we started talking properly in 2018, and we really had to kick off with an alliance of the willing. It was no way we were going to be able to make people sit around the table. We had nothing to offer them. It was early days, and it was just about people that A, had the capacity, and B, had the kind of strategic thinking and understanding of why it was important for us to be coming together as a sector. And the ideas behind developing 3ST, we're now third sector together, North West London, was to protect that influence that I mentioned, to provide the same simplified access to the huge voluntary sector that covers 8 boroughs, thousands and thousands of organisations, promoting the third sector as an integral part of the system. It's very, very common for us to be an add-on, and very much seen by statutory services as being about engagement and volunteering, all of which we are, but we're far more than that. We had a collective vision of how we could jointly improve population health and reduce health inequalities, and we also felt that jointly banging the drum for that investment that we managed to secure in Hillingdon in the prevention agenda and looking at the wider determinants of health. And we had, across the 8 boroughs, a number of partners, not just from Hillingdon, where we had very strong, proven models of saving, cost savings to the system. And we felt that there was a lot of scalable models that we could propose as something that was investable to really start to look at an 8 borough kind of offer. And we also wanted to make sure that we were working across the broader third sector in Hillingdon, and I'll explain how we did that. And promoting trust and reducing competition, I think that's been one of the biggest challenges, because obviously we have been divided by commissioning practices as a sector for a very long time, and trust takes time to grow, and it takes a lot of joint meetings and understanding and working together to start to grow that trust. And we also, again, wanted to protect North West London organisations and services to make sure that people that were providing help to residents understood the geography, understood the communities they were working within, rather than some of the big nationals. I'm sure there's maybe people from nationals around the table and we have no beef with them at all, but we do believe that local intelligence is really critical to making sure we meet the needs of our population. So the next slide, this is the working model we agreed. And again, this was very, very much not about the people that have the capacity to sit around the table. At this point, we had about 30 organisations from across the 8 boroughs as part of a strategic group. And they've elected a leadership group of, I think, 9 different people who do a lot of the drive at the North West London level. But we also had very uneven development across the 8 London boroughs. So some sector engagement with local ICPs was very strong, very well developed, in other areas less so. So we wanted to try and provide a very cohesive and consistent third sector sort of leadership in the voluntary sector, and to use the influence we were getting at North West London to kind of influence how ICPs engage with their sectors at a borough level. So really looking at levelling the playing field at that place level, but also, and most importantly, not forgetting the huge sector that is serving the population at a neighbourhood level. So by having the infrastructure bodies around the table who have their systems and processes and forums and alliances to engage with the rest of the sector, we are very much about looking at how we provide a voice for a much broader sector than just the people that are, the organisations that are engaged. So we continue through the infrastructure bodies to provide that infrastructure support. But we're very, very clear that any contracts that we secure at a North West London level are delivered most appropriately. And that might be, if we're looking at health inequalities, that money is pushed down to the front line to smaller groups and organisations that are working in the heart of the communities that we need to support. So we're having very much a lot of work happening at each of those levels, and it's not just about the 30 of us that are sort of sitting around the table. So just moving on to the next slide, the progress we've made in terms of the neighbourhood development. We've got all our infrastructure bodies around the table, and regular messages from 3ST are going out through health and wellbeing forums and alliances and newsletters and existing borough structures. We have started looking at data, minimum data sets. So really to make any headway and influence and to really engage with the system, we have to speak a language they understand, and actually looking at sort of data and impact is a biggie for the whole sector, I think. And we've been looking at how we can come up with something that's manageable and not too onerous for smaller groups and organisations, but that help us to use sector intelligence to really look at population health commissioning models. So just to put that in context, and I can't speak for the other boroughs, but in Hillingdon, the primary care networks have an arrangement with NHS England called the DES, the Designated Enhanced Services Agreement, and they have £9 million of funding that they can choose to spend at a neighbourhood level according to the needs of those populations. And we believe the sector has significant intelligence about the barriers to engaging with health, what works and what doesn't. And actually, the historic way of commissioning services at a borough level and then trying to shoehorn residents into them doesn't work. So we are working with the primary care networks to try and influence that spend at a neighbourhood level. So we've got very strong relationships with primary care and the Confeds, and we are just looking at how we can scale up some of the models that we know have saved money. So that's kind of where we're up to with the neighbourhood work. Just on the next slide, in terms of the borough progress. So we've now got seats on the newly formed borough leadership team. So there's 2 representations, voluntary sector representations at each borough leadership team for each borough. And we also have 4 representatives each borough on the North West London structures, so our strategy group. And we are really working with all those partners to kind of level out the engagement at the borough level. It's still uneven, but to try and influence local ICPs through the North West London structures to make sure that we are having our voice locally in those boroughs where that's not as well developed. And we also have a communications working group to look at some of the key messaging, both for the neighbourhoods and for the system and at a borough level. And then finally, just going on to the system. So we've been recognised, next slide please, we've been recognised by the system as the third sector representative, and we have seats on the ICS board and the 9 portfolio boards, and obviously a series of local care boards and working groups. That was helped by our engagement with the NHS England Third Sector Leadership Programme. We got a small pot of money from them, which is we invested in developing our governance, our joint working principles, and also a series of expectations of the system that we believe is important for us to be engaged, on an equal level. We've got a logo, we've got a very small website, and the details are there. There's not a huge amount on there. Let's never forget this is all on top of our day jobs, but we are trying to develop the website as we go along. And the expectations that we have put to the system about how we are treated and seen has been signed off by the board and is currently doing the rounds of the other boards. We have regular meetings with the chair of the ICS, Penny, and we were actually involved in the interviews for the new ICS chief exec, who's Rob Hurd, who's only been in post about a month. So we are now just looking at our commercial group, looking at the sort of models of delivery that we are punting to the system. So that's kind of where we're up to. The next slide really just details some of the challenges, which I'm sure you can all think of hundreds off the top of your head. I think trust's been the biggest one, but because we have been meeting every month for 3 years, I think particularly the leadership team is completely trusting of each other. And I think one of the biggest things was really making people realise that when they were sitting on these boards and working groups, that we're representing the sector, not just our own organisations. So it would be very easy for me to sit on a board and bang the carer drum, but every organisation around the table has its own issues. So we have to just take that step back and think about this is about the whole sector. There have been a few tensions between delivery organisations and infrastructure bodies. Obviously, infrastructure bodies have been banging the drum for all their membership and their smaller groups and organisations, and it took us probably about 8 months to settle on our working model to everyone's satisfaction, and that's how we came up with a 3-tier model. It's been difficult to engage with a backdrop of changing structures, new posts, new appointments, and still there remains a lack of clarity, I think, nationally about what ICSs are or might become, particularly attention about whether it's going to be predominantly a commissioning body or whether there will be delivery from some of the members as well. And I think that's still in debate. And I also think there's a general ignorance about the third sector and how it's funded and its reach, the real cost of delivery. I think there's a tendency at the moment for the NHS to see volunteers as a free solution to a lot of ills, but actually, as we all well know, managing, recruiting and supporting and training and managing volunteers is as time consuming and costly as managing your staff team. So there is a lot of education, we believe, still needed for the sector. And then the biggest challenge that I've actually missed off the slide, my apologies, is the data piece. So we need access to current and relevant data to be able to evidence our impact in a language and a way that is meaningful to the system. And we have struggled to always get the right data at the right time. So where we have been able to do that in Hillingdon. The CCG did all the data analysis for us, which was great, but we need access to that on our own. So we had a meeting this week with the system about how that could be facilitated. And in preparation for that, we have all done in NHS Information Governance Level 2, so that they are confident that that data and information will be treated appropriately. Just going on to forward priorities. So we've been, next slide, we've been involved in a series of workshops shaping the ICS. The biggie for now is leveraging the financial support. So we had a small amount of financial support from NHS England initially, but we are all giving a huge amount of time to attend all the boards and groups that we sit on. And we have just put forward a funding application for £250,000 to support our infrastructure. And we had this Chief Finance Officer for the system, Steve Bloomer, at our leadership group on Monday and explained in detail what that was about. So we have high hopes that Steve's going to come back with £250,000 for us, but it's not quite in the bag. But we've also put in a proposal for a series of models of working to the tune of 3.4 million, which I don't suspect we'll get all of, but really trying to evidence to the system how, with a bit of investment, we can actually contribute to systems recovery and, you know, closing the hole in that deficit. We have a series of working groups, and obviously if we are starting to get contracts to flow, we're looking at our commercial structures and supply chain management, and we have a communications group to look at the sort of messaging and education piece. I think we need to do more work on understanding the key priorities in terms of systems recovery. So each board you sit on has its own priorities, and it was really helpful to have the conversation with Steve Bloomer on Monday to really understand where the pressures are in the system, and that has really helped us to you know, really think about what we move forward with. So that's where we're up to. The next slide is just a question slide. I'm going to pause again and take some questions, and then I'll actually come on to the carer piece, which is I know what you're all here for.
Thanks. And I think when you get to that carer piece, we'll probably pick up on a couple of the things that have come up in these questions. So I guess the first you can just say yes or no to me if it's going to come up in the next bit.
Sure.
So one was around how you know you're providing what carers want if they're not getting that representation within that H for All.
Well, H for All, I'm not really... So H for All is not providing services to carers. Carers have their services provided through the Hillingdon Carers Partnership, and they have over 100 free services. The health and wellbeing services that are developed by H for All are not carer specific, they're for the whole population. So we in the Carers Partnership would never develop a service without, you know, consultation, and we have regular dialogue with all of our carers, and we never bid for funding unless we've got a proven need that service is, you know, needed. So carers are very much in the driving seat around carer specific services.
Brilliant. And I think there's something for me as well around having carers embedded within business as usual rather than being seen as an add-on. That's probably really helpful in that context.
Yeah, absolutely.
And then the next one, which again is, I think you've probably just answered, was about, do you have anyone embedded within UTC who offers carer support or signposting whilst a patient's being assessed or treated, or do you refer outwards to charities like the Alzheimer's Society? But I think you've probably picked that up, haven't you?
Is that a Hillingdon question, I'm presuming?
I'm guessing so, yeah.
Yeah, because there's nothing that's pan-London. It's all slightly different from borough to borough, as you might imagine. We don't have anyone based in the urgent treatment centre, although Age UK do have a discharge service. Age UK are a key partner, and what our joint working has done is massively improved cross-referral and has made carers everybody's business. So carers will automatically be picked up through the Age UK programme and sent to the Carers Partnership.
Brilliant. And just a few other, I think a really good one. You picked up on some of the challenges that you've seen, but I think quite an interesting question from Linda was, are there any sort of significant failures that you'd want other people to be aware of Things that you've really learned from?
Yeah, I mean, we're not got to this. This is a slick presentation about 3.5 years of work just to get to our structure. Saw all sorts of falling outs and debates and workshops and ways of, and it's taken us a very, very long time to, even though we had a kind of shared vision from the get-go, which was our first piece of work, to actually work out how we go from the vision to actually making it a reality has been, one step forward, 3 steps back, many, many, many times, because there's a huge number of voices in the process, and we purportedly, we purport to be completely inclusive, so there's no votes or people being overruled. We have to reach a consensus to get to where we are. So I would say, lots and lots. I think one of the bigger challenges for us was to get that recognition from the ICS. So we didn't sort of get the seats on the table until we could really evidence to them that we were trying to be representative of the whole sector rather than just the group of charities that had come together. We had to start with an Alliance of the Willing, but what happens is as your profile grows, we're now having to review our membership model so that we can be more inclusive, because we've now got, I take at least 3 calls a week from charities and organisations of all sizes wanting to be part of it. So we're discussing that the next leadership team a kind of model that gives North West London providers automatic membership and access to the logo, but that so we're having to reconsider stuff all the time. But and every time we take a step forward, it's challenged, and we have to kind of debate it at length. So it's been 3 years hard work to get to this place, really.
So I'm not surprised at all. I'm mindful of time, so I'm going to ask one more question from this sort of section, and then questions we don't get to, we can collate and either ask at the end or send on to you, Sally, if that's all right, and we can put answers to those when we send out the slides. So the other question I wanted to put to you was from Colin, which was around the structural changes that are happening across the NHS now, primarily with the sort of end of CCGs, and how do you think that will impact on some of the strategic decisions that you've been making and the future of H for All and 3ST?
That's a really good question that I don't know all the answers to. Obviously, we're still really waiting for the ICS to embed and make clear its intentions in terms of commissioning. I think I'm just going to find my notes with Stephen Bloomer yesterday, because actually he touched on some of this and I might be able to be a bit more detailed. But I think there is an overall plan that there will be some decisions that are retained at a borough level, at a locality level, maybe the community services. Obviously, all the acute and secondary care decisions will be made more centrally at a North West London level. And what we are trying to do is spread ourselves so that we are able to engage with the North West London CCG and ICS, or also still retain our seat and our influence at a local ICP level. So I don't think there's any clarity for us yet about what contracts will come through where.
Yes, and I think we feel the same from NHS England side of stuff as well. Yeah. Brilliant. So I'll pause on questions there. For those who haven't had their questions answered yet, please be assured that we will make sure those are forwarded to Sally, and where Sally can answer them, she will, and where we need to do a bit of digging, we will as well. But Sally, I'll let you do the final bit of your presentation.
Okay. So yeah, what I wanted, next slide please, what I wanted to do was really, obviously, H for All was on top of my day job, and then 3ST is on top of that again. And so I have to sense check why I'm doing what I'm doing for my trustees on a regular basis. I am paid to run the carers partnership. I'm not paid to do the other work. So I have to, every board meeting, I talk to them about how carers have benefited from our arrangements and why it's important that my time is still given to that. So through the H for All partnership locally, when I started in 2014 in this role, our identification rate of carers was around 17%. Through our joint working and because more people are cross-referring, we've now hit 39%, and that's because lots more organisations are far more carer aware and are referring people in. Because of the wellbeing services that H4All provide, we are able to support carers by getting more support for the people they look after. So particularly in the long-term condition management, carers were often, they were given a diagnosis and unless they were having an intervention from the health service, very much left to get on with that. But what H4All does is provide the education, coaching and support to improve understanding and management of those conditions. So effectively making their caring roles more easy and more manageable. It's given us, because we're sitting around the table with the GP Confederation, a significantly improved relationship with primary care. Prior to this, we were banging on the doors of surgeries, with little effect. In some areas, some practices are brilliant and not so much with others. But what we've been able to do through that relationship is now have a carer champion in each of our 46 practices, who has a sort of clear role to have a carer register, make sure they've been, referred to the carers partnership, to make sure they have good practice in terms of drop-ins for health checks, flexible appointments. I mean, obviously that has been impacted by COVID and we feel like we have taken a big step back with that, but we did get to a point where things were working much better and feedback from carers about engagement with primary care were much more positive. It's given us, our turnover as a local carers organisation has gone up from 400,000 to 1.4 million in the last 7 years. And that, is partly because of mostly because of our partnership working. Funders like partnerships, and it has enabled us to draw down a lot more resource to support our carers. And we've been able to influence in lots of ways, just the decisions that are made at Hillingdon Hospital and CNWL. And also many carers, as we know, have long-term conditions themselves. So there's been a lot more support for them as residents being able to access H4All services. The next slide. So obviously more money invested in the front line. We've saved a lot of money and have been able to set up new services because of the savings we've made. So carers benefit from the carers partnership in that respect. There's a lot more knowledge and expertise. I have a lot more expertise to draw on very quickly and very immediately, locally. Carers are more people's business. And actually the cross-referral from other partner charities has improved significantly and awareness has grown. There's no duplication and gaps in services, so we always kind of review where we're up to. So we hope that if we identify an obvious gap or a carer says there's a gap here, that we can collectively work to meet that. We have had much more success in grant funding because funders do like partnerships. And we've also had higher profile with the council and investment. So when the City Bridge Trust funding ran out and we got investment from the council, and they have also supported the carers contract. We've not had any cuts in funding and we've had an extra corporate grant to support it. And really the bottom line for me is not standing still. To survive, you have to adapt and change and grow and respond to the environment around you. And whilst the fact remains we are businesses and we have to function as businesses, and there's huge value to the partnerships we have in supporting us to do that. And then finally, the 3ST piece and how obviously, it's not had, next slide please, not as much influence yet because that's earlier days in terms of the work, but we're working very closely. I know Charmian's around the table from Harrow Carers. I'm not sure if Sally's here from Carers Network, but we're working very closely with our colleagues. Even though we do that through our National Body Carers Trust, we are looking at, much closer working with a North West London focus with our carer colleagues. And actually that's led to Charmian and I developing a cross-borough young adult carer service for across Hillingdon and Harrow. So we're looking at cross-boundary services to share together in those, which is really as a direct result from that closer contact through 3ST. I would say, Charmian, wouldn't you? Yeah, nodding there.
Absolutely, Sally. It's really good. It's really worthwhile to do this. Yeah.
Thank you. One of the results from the system, which is worth mentioning, and this came from Charmian actually, was that the ICS had designated leads for all sorts of things, but didn't have a carer lead. So we challenged them on that, and they're now appointing a carer lead for the system. So we've been able to make some change there. And actually, we've been able to use some of that North West London influence to get that sort of levelling out at a local level. So seats on borough leadership teams, better engagement with ICPs, etc. And I do believe the trust's growing. We support each other all the time. We have a whole resource of people to approach and, sense check things with. And it's been a really sort of beneficial brains trust, I guess. And then finally, that's just the last slide to show the support we have politically for our carers, because that's the second visit that the fabulous Boris made to visit carers, which, just gives us an opportunity to really share with him about what it's like to be a carer, and for carers to share with him what it's like. So just some reflections from me about recommendations. Learning the language is really important. Being able to talk to people in a way that's meaningful to them, and understanding those challenges the system have. Being proactive. They are not able. They don't understand how to come and get you involved because it's too big and too dirty. It's too diverse, the voluntary sector. It's far easier to get together with peers and present them with solutions, and that's what we've been doing. I think we've been banging on doors and very persistent, and you have to be persistent and you have to be prepared for some very, very hard work. I'm quite happy to share our expectations paper, which will soon be added to our website, but has just been sort of circulated at the moment. But it's about being very clear what your expectations are from the get-go, so that you are treated as an equal in the system. And I would recommend the learning from the NHS leadership programme. And that's all I'm going to say. Thank you.
Well, so you thought, but we do have quite a few questions for you, Sally. So I'll let you have your glass of water while I scroll down. And I am mindful of time, so I will sort of pick and choose a bit. Another question from Linda around how have you taken forward the need to change existing cultures and find a single vision or culture or way of doing things going forward?
Single vision for the voluntary sector?
I'm guessing so, yes.
Yeah, so part of the offer from an NHS England leadership programme was some support from what was NCVO, I think it's now NAVCA, and we had a full day's workshop where we did the visioning. So we had a shared vision, mission statements, and then through the investment we employed consultants to work up a series of joint working principles, which are available on the website, which if you go, well, I'll put that in the chat for you in a minute, but it's just 3stnwl.org.uk, and the joint working principles are there. And that was really just a commitment to how we were going to work, how everyone should be valued, and how we would make sure that we were as inclusive as possible. I've forgotten the question now.
It was around how you get that single, how you get people working towards that single vision and challenge some of the culture.
Yeah, and I think, just by having the meetings we do, particularly the leadership team, which is, meets every month, you end up talking each other around and having that shared narrative, and all decisions are then taken back to the strategic group for sign off. We don't make any decisions without them.
Yeah. Good questions are from Helen, and I think this kind of links into what you were saying about the carer champions at a GP practice level, and asking about, do all GPs ask patients when they register if they're carer? And I'm guessing it's probably more often not the actual GP, but people like receptionists and
Yeah, and the champions are actually, some are GPs, some are practice managers, some are practice nurses, some are receptionists or head receptionists. It does still vary. It's like painting the Forth Road Bridge. We have champion forums where we showcase good practice in the surgeries, but it is very uneven. But it should be the carer champion that is pushing the practice to identify those carers in whatever way they see fit internally. I can send you the carer champion role description.
That would be great. And I think it's interesting. So I don't know if Charlotte is on the call today, who's the regional lead for the Southwest, but we had an event yesterday, I think. I'm losing track. The week is flying by. And one of the questions came up around carer champions, and I knew of examples where it had happened locally to me in Hertfordshire, but really nice to see other examples of it. So I think it'd be really great to sort of share how that works.
Certainly, I'll send you.
I think there's huge value in having that sort of person within a provider group actually saying, are you asking about this, and really pushing it.
I mean, one really sort of big thing for us was some good practice. Some practices are brilliant, and we were actually invited along to their CQC inspection to talk about how we supported them to support carers, which we've showcased to try and get others to do the same.
Brilliant. And I'm just going to squeeze one last one in because we're almost at time. So a question from Sarah around how do you engage with carers to find what's working well and not so well, and where the gaps in support are for carers so that they get what they really want and what will make the most difference to them?
Okay, well, we have any number of mechanisms. We have carers forums. We evaluate every activity immediately after it, and if it's a learning activity, pre and post, to look at the impact of that learning. The staff also will, so if we're doing anything big like a new strategy or the rebrand we did, we will have bespoke consultation programs, and I'm trying to think what else. We have evaluation surveys, so we've just taken over the We Care survey, annual survey through national body, which gives us benchmarking opportunities to look at the impact and perceptions of our services against national picture. We do, and we've got the impact framework, so we've now just started to use a series of tools to measure the impact of our services on carers' lives. So lots of ways. I mean, I could do a whole hour on that, really.
Next time. So we'll close there, and just want to say, Sally, huge thanks. That was a mammoth task, presenting so much information, and I think really heartening for me to see that population neighbourhood based approach to health and well-being, because if you look at the data we get from our GP patient survey, the issues that carers are having are deeply rooted in the sort of wider population health issues. So if we can make carers a significant part of the population in that context, then I think we're really going down the right track. So absolutely wonderful to hear about the work that you've been doing, and thank you so much for giving more of your unpaid time to us today. But hopefully what it will do is spark a lot of conversations, and looking at the chat box, there's a real appetite for learning more and sharing. So we will obviously share these slides. There have been offers to share other bits of information as well. I think we've seen Calderdale, Portsmouth, all sorts of places saying that they've got bits and pieces they could share. So please do send that stuff into Steve on our generic carers email address. We can pop that in the chat box for you. But huge thanks to everyone for your time today. These sessions are so well attended. It's been really great. So hopefully we can continue to bring such valuable and important presentations. And I will give the final word to Ros. Sorry, Ros, did you not expect that?
I wasn't expecting that. Thank you so much, Sally. That was really interesting. And I think the thing that sort of stays with me, and I think Jen touched upon this, is it's very much a case of it is about the whole population. And yes, there are people within that population that have different needs, including carers and many other communities. And actually, it's about working across that. So we're not putting people in silos, and they're not at risk of being put to the side and not being heard. And that was what came across so powerfully for me. So thank you so much for sharing that with us. And I certainly found it inspiring, and I know lots of other people from the comments did as well. Thank you.
Thank you.
Thanks, everybody. See you next time in May.
Bye.
Bye-bye.